Good evening and welcome. I'm Melanie Ramey, Chair of the Madison Committee on Foreign Relations, and it's a pleasure to welcome you this evening to this very important event. We are not able to meet in person tonight, and because of that, we were very fortunate to have with us Dr. Richard Laing from Boston University, who is a retired professor in global health in their public health division. Now, Dr. Laing is a true expert on all sorts of things to do with world health. He worked for 18 years in the country of Zimbabwe. He is a medical doctor by profession, but also holds advanced degrees in other areas. He also has a interesting title in one of his present positions, and it's called the Extraordinary Professor. Now, I don't know what that means. I don't know if it means that he's an extraordinary person, which I suspect he is, or if it's just a particular title that they use there. But it's fitting for him because he is definitely an extraordinary person. He has worked in the private sector, and he is also busy now, also helping to develop a pharmaceutical program for all of Africa. Dr. Laing spent 10 years working as a medical doctor in the World Health Organization. And again, there he worked on the development of medicines and making medicines available. So he is really an expert in many areas of the world. And that's why the World Health Organization and its work in all the countries of the world is something he's very knowledgeable about. So we have had many disappointments, of course, with the pandemic, but one of the good things about it has been it has allowed us to be able to reach out and have people with us like Dr. Laing that perhaps we would not been able to have had his presence if we had had to meet in person. So I know you'll join me in welcoming Dr. Richard Laing, and we're anxious to hear what he has to tell us. I would also say to you to look at the bottom of your screen and click on the chat. And over on the right-hand side of your screen will then be a column. And in that chat column is where you can put your questions for Dr. Laing. When he has finished his presentation, I will present the questions to him. So I know he will stimulate many discussion questions for us, and also will give us lots of much needed information. So without further ado, I welcome you, Dr. Laing, and we're so happy you're with us.
Well, thank you very much indeed, and I'm very pleased to have a select and interested group. Scott, I wonder if you could show my slides. As has been mentioned, I have a background of working in the health systems in Africa, in the Ministry of Health in Zimbabwe, and also here in the US as a consultant, teaching public health in Boston University, working for WHO in Geneva, and for the last 6 years until I retired last year, again at Boston University in the School of Public Health. Next slide, please, Scott. The issue, what I'd like to talk about is why is it important for Americans to know and care about WHO? And the first issue is that health is and always has been a global concern. The US has much to gain and something to contribute to WHO. The US health system is rather unique, and very few other countries aspire to have an American health system, but there are many aspects within the American health system that can be shared. I think knowing the capabilities and limitations of WHO will enable US policymakers and citizens to have realistic expectations. I think what struck me in the last year was the wild, fantastical ideas about what WHO should be doing, could be doing, is not doing. WHO is both a technical and political organization, which is not surprising. Public health, that is the nature of public health. But this has all the strengths and contradictions that that brings. And I'm hoping we'll have time to talk about some of those issues at the end of my talk. And within the organization, tensions have always existed between a disease focus and a health focus. And again, that's an issue that particularly people with an interest in development and development theory can relate to. Next slide, please. So I'll give a very brief history. It was established post-war, post-Second World War, April 7th, 1948. And it was very much based on the Bureau, the Health Bureau in the League of Nations. But that was a very narrow group, organization, the Bureau. It focused on leprosy, malaria, and yellow fever. So it was very much a disease-focused organization. But it was also strongly influenced by PAHO, the Pan American Health Organization, based in Washington, but which has had a presence in all of the Americas, but particularly in Central America, and that they focused on health regulations and epidemic control. And they had been doing so for more than 50 years at the time. So WHO took that on board. But one of the key elements of the WHO Constitution was this definition of health, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And it brings this ongoing tension, the tension I've already mentioned, between disease focus and health systems, health service, health status. Next slide, please. So a very brief description of structure and a little bit about some of the other areas of activity. So the headquarters is in Geneva. The building is there. We've seen lots of pictures of it. And sorry, if we go back one, Scott. The political element of WHO is the World Health Assembly, which is made up of ministers of health. They meet every year in May for 1 or 2 weeks, depending on whether it's a budget year or not. And the executive board, which is a bridge between the member states and the secretariat of the organization. This is not generally made up of ministers of health. It's often permanent secretaries, the director of health services, and it brings together a very impressive group of technical experts. They have regional representation, and they represent also the 6 permanent members of the Security Council are represented on the executive board, either directly or indirectly. The Secretariat revolves around the Director General, a Deputy Director General who's like a Chief of Staff in a way, and then multiple Assistant Director Generals who head up different divisions. And these include disease-focused divisions, health determinants and health systems divisions, an emergency response group, a data group, a communication group, and the general administration that a big bureaucracy would need. In addition to the central function, there are 6 regional offices. Now, these offices were established in the late 40s, and so the political allocations can be a little confusing. Why would anybody choose to have Brazzaville as an African center is a little open to question. But the other regional offices cater for their regions. Now, some countries belong to regions that you might not think they would belong to, but that's the way the compromises were made. There are 194 member states, some with country offices and some with liaison offices. And these are small offices in the country, often staffed by nationals, and they act just as a liaison communication. But in countries where the WHO has a representative, the WR, he is the ambassador for health, and he plays a very important role communicating with other ministers, but also with other ambassadors. In terms of the technical work done in the country, that is not something the WR gets much involved in. But depending on the size of the country, the funding for the country office may have a variable number of technically competent people who coordinate programs. In addition, there are 800 collaborating centers around the world. These are based usually in academic centers, but sometimes in institutes of health and organizations like that. And they play a very important role, and WHO in many cases delegates technical areas of responsibility to these collaborating centers. And often they don't get the prominence and the recognition that they are due, but they play a very important role in the technical expertise of the organization. WHO has 7,000 staff, and that may sound a lot, but if you compare that to Médecins Sans Frontières, which is one of the newer or one of the first NGOs with a global health mission, they have 35,000 staff scattered around the world. The budget for WHO again is 5.84 billion for 2 years. It's a biennial budget, which amounts to 2.9 billion a year. Now, putting that in perspective, Boston University Medical Campus, where our School of Public Health is lodged, they have a budget of $2.42 billion. And if you think that there are 3 other teaching hospitals in Boston, all of which have similar or larger budgets, you can see that WHO is actually a relatively small funded organization when you compare it to the many different teaching hospitals that are around the world. And where does that budget go? And one of the challenges is that 69% of the WHO budget is specified for earmarked programs, where funders say, we'll give the money to WHO, but they must use it for example, polio eradication. In terms of the regular assessed contributions, this is like the membership fees that countries pay into the organization. This has dropped from 46% of the total budget in 99 to just 17% last year. So this is the core budget that the administration, the Director General has, that is flexible within the control. But this challenge means that it's very much a difficult task to reallocate when so much of the budget is earmarked. Next slide, please. So what does WHO do? And it really does 5 things. The first and the most widely accepted, recognized, and utilized is norm setting. So for example, WHO defines the names of diseases, the ICD-10 classification. It also sets the names for new medicines. Every new medicine that is developed is named by this WHO committee in 6 languages, the INN, the International Non-Proprietary Name. Other companies will come up with their brand names, but when that product becomes generic, it is marketed, it is produced in that way. WHO also produces the Essential Medicines List, which is a limited list of medicines that is defined as what every health system should have available to their people. And I was a member of that committee, and then when I worked at WHO, I was the secretary of the committee. I can point out the expert committee report in the top right-hand corner of your screen is the vaccine and medicine specifications. So for every medicine, for every vaccine, specifications are defined. Now these will be formulated into pharmacopoeias, but the manufacturers, the quality control people, anybody who wants to know, is this medicine of adequate quality, has to follow those specifications. And the last area that I've quoted is the international health regulations. These were last updated in 2005, and there's a lot of pressure to update them again to make them more responsive. So that's the first area, norm setting. The second is the convening experts and policymakers. And because WHO is a truly global organization, they are able to get the best and brightest from wherever they are. And I mentioned the committee, the guidelines for opiate dependency. And I remember helping organize one of the meetings, and the chairman was an Australian. The three of the dominant members of the committee, the one was an American, the other was a Brit, and the third was an Iranian. All countries with substantial opiate dependency problems, all countries that have chosen different strategies and ways of going forward. And yet these experts work together incredibly hard to come up with optimal guidelines that would be globally acceptable. There's also a role for policymakers, sometimes less common than the guidelines for technical issues, but the Framework Convention on Tobacco Control has had a dramatic effect, more so in low middle income countries, in my observation, than in other countries. The US is well ahead, but in Europe, you still are seeing smoking in restaurants, for example, which you would no longer see in most African and Asian countries. The third area is surveillance, and there the WHO has a global health observatory that acts as a repository around different areas of health. They have the monitoring, the international health regulations monitoring, what is happening, where are there any reports of any outbreaks of disease, and they produce World Health statistics in specific areas. This was a much more important area of work that has now been replaced or overtaken by the group based in Washington, the IHME, the International Health Metrics Organization. And the fourth area is information, global information that is generally accepted as being objective and with limited political bias. Now, that may or may not be completely true, but in general, it is better than anything else that is available. And so the imprimatur of a WHO logo, a WHO report, is important for information that people can depend on. Next slide. So I'd like to very briefly run through the history of some global health eras and show how things come and go and there's a pendulum swinging. The 1950s and 1960s was an era of disease focus. It was an era of great success with smallpox eradication. Now, what's not often recognized is that smallpox was eradicated in the middle of the Cold War through a very active cooperation between the Soviets and the Americans. The Soviets came up with a freeze-dried smallpox vaccine that could be stored in a glass vial. And when the glass vial was broken, the skin could be scarified and the smallpox delivered under any temperature anywhere in the world. So that was a technical innovation. And the CDC came in with very sophisticated contact tracing, where every case was identified, all the contacts were traced and immunized. And then over time, 1 kilometer, 5 kilometers, 10 kilometers, and eventually 40-kilometer ring vaccination occurred. And that was the strategy that defeated smallpox. We also had a very embarrassing failure, the world had an embarrassing failure, of malaria eradication. Malaria, after the Second World War, there was this idea that the wonder medicine, the wonder insecticide, DDT, could be sprayed in such masses that mosquitoes would be eradicated wherever malaria occurred. And of course, in some temperate climates and in some island situations, it was somewhat successful. But the vast majority of tropical forests were not able to deliver the DDT. Enormous damage ecological damage was done. And eventually by the late 60s, the recognition was made that this was a complete failure. We don't hear much about that failure. The smallpox was the great success. The 1970s, the pendulum swung to the health approach, saying, how can we improve health? And there, a visionary Director General, Hafton Mahler, pushed the idea of health for all through primary health care. Primary health care was not primary medical care. It was looking at what is needed at individual, household, and community level to ensure a healthy environment for everybody. And it really came, the Alma Ata Declaration at the time was a critically important document. Small, but it made an enormous difference. And for me, working in rural Zimbabwe, when I read that, it totally changed my approach to what is health all about. But the things changed in the 1980s. There was an immediate reaction led by the Rockefeller Foundation, but also by CDC and by UNICEF, who said, well, that's very broad, that's very too much, can't do it all. Let's focus in on a few selective interventions. And this was selective primary health care. And the different organizations chose different packages of interventions and put a lot of effort into them and did make a difference in whether it was measles or diarrhea or malaria, but it didn't make things better overall. WHO plugged away, and the expanded program of immunization was launched and extended around the world, but it was very much as a health system support and strengthening. And the essential medicines approach of saying, what are the key essential medicines that need to be available everywhere, always, was also very much a health system strengthening innovation. The 1990s, the World Bank got involved, and they produced what was a very influential report. The World Development Report in 1993 was titled Investing in Health. And that shifted the emphasis to say health is the financing of health is an individual and a state responsibility. And individual health, individuals should pay. And the cost recovery and revolving funds and approaches like that, while some of the public health aspects could still be funded by the state, but with structural adjustment and squeezes that went on, it wasn't really. And so in many ways, that era was a step back from access to health or improving health. And it was complicated by the emergence of HIV and AIDS, and WHO missed the boat. Jonathan Mann came in and tried as hard as he could to mobilize the organization. It was pigeonholed and isolated. We also had the conflict around intellectual property and health. And in this situation, Scott, if we can get back to the slide, the issue of intellectual property was driven by the HIV/AIDS program, where people were saying, why should people die in Africa or wherever it is? Can we go back up, Scott? A few slides up. And die of a treatable disease purely to protect the patents of the companies. And that fight went on. The big pharma sued Nelson Mandela. And I always remember there was an editorial by the Wall Street Journal saying suing Mandela is not good for your company health. And eventually the companies withdrew and a compromise was reached where those medicines were made available by Indian generic companies and millions of people were treated. The 2000s, we saw the start of SARS, which was a coronavirus, started in China, exploded in Hong Kong, traveled to Canada, but was controlled with epidemiological methods. There's no vaccine for SARS, but they controlled it. And Margaret Chan, who was the health director in Hong Kong, managed it through quarantines and isolation, contact tracing. And as a result, she became an assistant director general and then a director general of WHO for 10 years. But the 2000s was an era where WHO lost influence, where we saw global health organizations explode, where we saw the Global Fund for AIDS, TB, and Malaria come in, a very focused disease control organization. In the last few years, they've done something on health systems, but only as it relates to their diseases. Gavi, the Global Alliance for Vaccines and Immunization, and Gates Foundation, where Gates is becoming in many ways even more influential in their choices. The IHME I've mentioned has taken from WHO's capacity and to provide surveillance. And we also have UNITAID, which is a very interesting, a French initiated program that used a levy on aircraft flights as a way of funding, again, primarily around AIDS. The one interesting aspect that happened in 2000 that doesn't get much attention was a commission on social determinants of health, driven by somebody, Michael Marmot from the United Kingdom, who clearly identified that in every society, doesn't matter rich or poor, you can look and say, where are the health problems in the country and how much of it is socially determined and how much is it access to health services. And of course, in the vast majority of cases, 70 or 80% of the health status of individuals does not depend on health services. 2010, the epidemic started coming. MERS, which was more fatal and less effective, the Ebola epidemic exploding in West Africa in a way that had never happened before, and yet was controlled eventually, and a very good vaccine came out to deal with that. At the global level, the United Nations General Assembly got in the act and said non-communicable diseases matter. Heart disease, diabetes, asthma are really important for countries. The burden of disease now is 60% non-communicable diseases. And WHO came into that process and developed a global action plan on non-communicable diseases with a minimal budget. I mentioned the limited numbers of staff, but who would believe that the whole of WHO has one person dedicated to diabetes in the whole organization? Now, in 2020s, we've got COVID-19, and we'll have, I'm sure, time to talk a little bit about that. But next slide, please. So what are the ongoing issues? And I would like, if we can, to have some discussion about these, because COVID will go, but these issues will likely to remain. The first is the issue of disease focus or addressing the determinants of health. And it has been a pendulum swinging different ways. And even during the era of the 1970s and 80s, which was the alma ata, the primary healthcare, universal health for all, disease control programs like the control of diarrheal disease or acute respiratory infection were a major part of the organization. And polio eradication was a major source. It was the amount of funds that were poured into polio eradication. It's more than 20 years since polio was meant to be eradicated in the big plans, and yet it still isn't quite eradicated. Whether it will be there this year or next year is an open question. I remain personally doubtful. The second issue that faces WHO is who should determine the priorities? Should it be the donors who politically are very happy to support maternal and child health, and yet now the burden of disease is on NCDs? But NCDs are seen as diseases of sloth or people eating too much, drinking too much, not exercising enough, smoking, and seeing that it's almost their fault. And hospitals. In low middle income countries, hospitals consume 40 to 60% of the total budget of the health sector. WHO doesn't have a division that deals with hospitals. If a country goes to WHO and say, we need help sorting out our hospital sector, there's nobody there to help them. There's individual technical experts who do work in hospitals, but really it's not a coherent program at all. The third tension issue is this magic bullet approach or a health system strengthening. And the magic bullets, and we've had all sorts of magic bullets, whether it was DDT, oral rehydration solution, vaccines. These have been promoted to the exclusion of other health promoting activities. And these efforts do change mortality from those diseases. But at the end of the day, the overall rates frequently remain the same. And the Gates Foundation has been very strongly supporting the magic bullet approach. There's one exception. Gates has actively supported the Public Health Foundation in India, which has had a disproportionate influence on shifting India from a very medical, disease-focused and rather neglectful situation. The last area is one which I think everybody on this talk can relate to, is the tension between science and politics. Now, I'm not going to go into Trump and Fauci, but in WHO, the political will is sometimes very strong for doing activities that make no sense. And one of these, the example I quote, is a local production of pharmaceuticals. Year after year, resolutions come out of the World Health Assembly supporting local production of pharmaceuticals. And yet it's very clear that a country with regulatory capacity, limited scientific ability to produce basic fertilizer or agricultural products really should be avoiding getting into local production. And yet donors, funders continue to pour money into it. I did a review for the World Bank in 2005, and the World Bank bought that idea and stopped investing in pharmaceutical production in small, low, middle-income countries. Next slide. So how do we go forward? What can the US do? The US has rejoined, as Melanie mentioned in the first introduction. But will it re-engage, and how actively will it re-engage? Will the funding be general, or will it be specific earmarked funding for specific areas that are politically more palatable? Human resources, I would argue, is one of the most important areas where the US can engage and make a big difference. Traditionally, senior CDC staff have rotated through WHO, not just through the headquarters, through the regional offices, but through country offices. And because the CDC is such a preeminent epidemiological organization, the training that they can provide, the leadership that they can provide in countries has been beyond belief. It's a secret that people don't know about, and yet time after time, you find the people leading the way in countries have been worked with CDC folks. And so I have the highest regard for the CDC people who go overseas. The next one is encouraging recruitment of US citizens. And within WHO, there is a quota system where when you have advertise a position and applicants come in, you have to look and say, are they of equal qualifications? And then give preference to countries, people from countries who are underrepresented. And the US consistently is underrepresented in WHO. Part of the reason for that is doctors in the US get paid such enormously high salaries compared to what WHO can pay. It may not be attractive to those people. But health educators, some of the environmental health people, there are very many valuable US people who could work in WHO. I would strongly support the retention scheme. At the moment, US citizens who work for WHO have to pay tax. Every US citizen has to pay tax wherever they are. The US government refunds those taxes to WHO, who refunds it to the individual, which is an enormous incentive for American citizens. All other countries make they exempt their citizens from paying tax. There's recently been established a WHO Academy in Lyon. The French government is supporting it, and yet it brings together some very progressive educational ideas, which the US, with its broad educational capabilities could, I believe, contribute to enormously. And then the WHO collaborating centers. I do hope that there will be continued and expanded support for WHO. The issue of what will USAID, what will their relationship be to WHO is an open question. In the past, I've seen different aspects of USAID support WHO, compete with WHO, and in many circumstances completely ignore WHO. It would clearly make sense to have a coordinating activity, a coordinating group between USAID and WHO to coordinate activities in the world. So next slide, please. So my questions that I'd like to ask participants to contribute to, if there's time, is to talk about the issues. And if Scott, if we could go back the 2 slides to the issues that I raised. I have got one other slide about COVID that we can get to if there's time, but I'd really like to initially, at least, start with comments or questions about any of these 4 topics, because I think this is the long-term future. Thank you very much.
Dr. Laing, I have a question about who chooses the Director General of the World Health Organization, and is this person a medical doctor always, and for how long do they serve in this position? It seems like a huge job.
Yes, they're chosen by the executive board. In the past, it was a lot of suggestion of bribery and corruption in the selection. And one of the Director Generals, there were very well documented examples of funds being transferred. But recently, it's been an open process where individuals have been nominated by their countries. They've gone and circulated around to the different regions, to the regional assemblies. And then there's been a series of public interviews where people have been interviewed by the executive board online. And from that, it's become very clear what are their technical capabilities. And the last time around, there were 4 extremely competent candidates, all of whom would, I think, have done a very good job. At the end of the day, countries vote in blocks, but those blocks never hold together. And what we saw is with the Ethiopian gentleman who is now the Director General, the European bloc split. They had a British person who had been Deputy Director General and an Assistant Director General, David Nabarro, much older, much more experienced, and yet a number of the Europeans chose to support the Ethiopian applicant. They don't have to be a doctor. They have generally been a doctor. There was a convention up until Margaret Chan was elected as Director General, was that the Director General should not come from a Security Council member country. Margaret Chan changed that, and she was elected and did it in that way. They serve 5-year terms, and they're allowed to serve 2 5-year terms. Okay.
You mentioned that there are 194 countries that belong. Are there any countries that don't belong, that refuse to join? Or?
Well, of course, there's Taiwan that wants to join, and every year for many years at the World Health Assembly, the first day was spent over a dispute of whether they would be seated or not. Recently, there's been a compromise as far as that goes. No, I think just about every country wants to join because there are so many advantages to it. And the countries which don't pay their dues takes a long time to get them kicked out, and their voting rights get suspended and that. So in general, most countries are joining. Sometimes they function as a collective. So the Pacific Islands, they don't all individually send somebody to the World Health Assembly. Different countries may group together, and so you'll have that. But for the small countries, even some of the smallest countries will be sending their representatives. Thank you.
You know, you mentioned here the issue of the magic bullet approach or health systems strengthening. Does the magic bullet approach, though, sometimes strengthen the health systems? Now, I know for one thing, there's been a great effort in the last 15, 20 years for the eradication of polio in the world. And this has involved lots of different organizations, of which the World Health Organization has been one. But in eradicating polio, as these organizations have gone into the different countries to give the polio vaccine and so forth, are they not at the same time strengthening the health systems of those countries?
Well, the true believers would tell you yes. In my experience, the observation, one of the key approaches to polio eradication is mass polio campaigns. And the reason why they're so popular is with the oral vaccine, children will excrete vaccine into the environment and other children will be infected with that vaccine. So there's a good scientific reason for saying, if we want to eradicate polio, let's get as many children as possible immunized. Now, sounds great. The only problem was I was working in the Philippines 15, 20 years ago on a women's health and safe motherhood program. And one of the difficulties was for the month of the polio campaign, nothing else happened. All health workers were seconded to the campaign. So if a mother had a postpartum hemorrhage, they would probably not find anybody available to care for them because they were so busy doing the alternative. We saw this with the AIDS program. When the AIDS treatment program first came in, we saw organizations advertising for health workers, paying them 4 or 5 times as much as what they were doing in their regular health workers' job, and they were parasitized out of it. So I do believe that the expanded program of immunization, the essential medicines program, did strengthen health systems because they were broader, they looked at multiple disease areas, they were looking to sustain an activity rather than to have a campaign or have a one-off affair. So, but you will find people who are true believers in the value of these magic bullets. And I doubt if people like me, who's a true dissenter, will ever be convinced, and I'll never convince some of them. But it is an issue that I think is important. I have seen very good health systems in Sri Lanka, where they integrated the magic bullets into their ongoing system. They were able to bring about a dramatic decline in infant and child mortality rates and build with that on immunization and water and sanitation and diarrheal control and treatment of common childhood infections. Thank you.
You know, another question I have is about private foundations that go abroad and have projects. For example, we have one here that's been in existence for a long time, and it's to deal with vision. And so they go every year or so and do cataract surgeries. Now they started out in India, and now they've spread to Pakistan and I don't know, another country or two. So they do the cataract surgeries. They can do both eyes for $20, for example. Now this is a private foundation that exists. The president of it is an ophthalmologist. And so when they go into a country, do they call up the World Health Organization and say, we thought we'd let you know that we're going to be doing this and that? Or are all these other little sort of individual projects just sort of separate, off on their own somewhere?
Sometimes. And donations and donation programs have positives and negatives. So WHO developed some years ago or 20 years ago, WHO donation guidelines to try to coordinate guidelines, because many pharmaceutical companies were dumping short-dated medicines into these environments to avoid the cost of destroying the medicines. Those guidelines have worked extremely well, and there's a partnership for quality medical donations supported by the industry that does very well to coordinate and improve and ensure that donations are sustainable and actually meet national needs. A project like the eye, the cataract, we also see that with club feet, and we see that with surgical cleft palate programs occurring. Those can vary from being very isolated to actually being quite supportive. Surgical training in low middle income countries is a difficult task because the expertise may be limited. And I don't know if you're talking about Project Orbis, but Project Orbis was a similar eye improving the quality and providing cataract surgery, but a wide range. They would organize a preliminary prep team going in, meeting with all the ophthalmologists and doctors interested in the condition, running training courses, and then working with those individuals when the aircraft came in, or other people have used ships in a similar way. So I think it is possible for these programs to support. Now, what's the role of WHO in this? It depends very much on the relationship between the charity and the government. So if USAID is supporting it, and frequently USAID does support, whether it's just in tax waivers or in access waiving duty on getting products, they can make things easier. And frequently they will be introducing the team to the WHO representative, who may well say, well, do you know about the German group, Christoph Blinden mission, for example, that is doing similar work? Can you coordinate with him? Can you see, are you covering all the areas of the country? Maybe you want to be in the capital and Christoph Blinden wants to be in the capital, but the regional office, the regional cities don't have anything at all. How about sharing up the situation? So the WR can have a coordinating role that can be very useful, but that is often done through the missions, through the USAID mission or through the US Embassy or the country embassy, who the WR has very good contacts with. Thank you.
With regard to your expertise in pharmaceuticals, as you probably know, there are organizations, and I think certainly more than one in this country, that go and collect up prescription drugs that have expired, and then they send them to third world countries, is my understanding. Because the idea is that even though they may be expired, you know, even if they're half effective, it's better than them not having any. What is your feeling about that kind of thing?
That is an absolute disaster, and it sinks the country's health service. I used to run a course on drug policy issues for developing countries. And after the Rwanda genocide, countries were flying in, or organizations were flying in container loads of medicines. And the first container load that arrived, and there were only 4 pharmacists left working in the Ministry of Health. And they went to the airport after the containers had been dumped, and they were almost entirely useless. They weren't labeled in languages that people understood. They were as you say, they were expired. The packages were partially open. The conditions that they'd been stored in was completely unknown. So what they did was they took the containers to the end of the runway and had prisoners, people who participate in the genocide, dig enormous pits at the end of the runway and dump the products in. The only problem is people came and dug them up and started selling them, not as therapeutic medicines, but as mood euphoria. So this chief pharmacist for Rwanda told me that the next time they came, that he had spoken to the customs officers, and when the containers were about to be unloaded from the planes, he was standing there saying, under no circumstances can you unload them. And so that's why there is this the WHO interagency guidelines for drug donations or medical donations. 17 organizations have signed off on it. And if you know that group that is doing that, please tell them not to. They are making things much worse. If they want to help, give money. You can purchase those medicines at a 20th or 30th of the cost that you pay for them here in the United States on the international generic market. And when I was in Geneva, just the time I was leaving, Syria emergency erupted. And there we saw in supermarkets advertisements for saying, if you have medicines, bring them to this church hall, we will collect them and we will drive them through Turkey to get them to Syria. I went and saw the people doing it, showed them the guidelines and said, buy the medicines. Turkey has extremely well-developed medicines procurement systems. With the same amount of money you're spending driving to Turkey, you can get far more medicines than you could possibly collect in this way. So please don't, please under no circumstances do that sort of thing. Or well-meaning, but totally destructive.
I was going to comment, I know that the country of India has developed a tremendous pharmaceutical industry, as I understand. Do you think, I know you've been working with African countries in the whole area of pharmaceuticals, do others have the capacity, or could they develop the capacity to do some of their own production of different pharmaceuticals?
Yeah, India is a fascinating situation, and I've done quite a lot of work there. India has the best and the worst of pharmaceutical production. And the reason they do that is they have decentralized the regulatory authority to the state. Health is a state responsibility, and so each state has its own regulatory authority. And so there's at least 25,000 small-scale manufacturers frequently operating in states with very limited quality control. In other states, Rajasthan particularly, and a few other states, you have the very best generic manufacturers, the Ciplers and Hetero and Herrero, and AIDS treatment in the world wouldn't be as it is without the Indian manufacturers. So in terms of countries producing their own pharmaceuticals, it's after aircraft, pharmaceuticals are the next most severely regulated technological production. And if you have a country which doesn't have the technical educational system, the people to maintain the HPLC machines, the quality assurance, the regulators who can actually do a good manufacturing practice inspection, it's going to be extremely difficult to assure the quality. What we've seen in some countries is the government providing preferences to their own government, to their own manufacturers to stimulate that production. The cost of those medicines nearly always is far higher than the cost of importing from good generic suppliers. And those generic suppliers are frequently Indian, but they may also be Chinese. And in the past, they were also Southern European countries, Romania, Bulgaria, even Spain, Portugal, had generic manufacturers that were very competitive. But in general, and as you say, if anybody's interested, the report that I did with somebody called Warren Kaplan for the World Bank continues to be influential on that topic, saying, don't do it if you're not big enough to do it properly.
Just to clarify, for example, if the Director General has a meeting of representatives from the member countries, who represents the United States? Would this be the head of the CDC, or who would be the person that they interact with mostly in this country?
It depends very much what the topic is. For the World Health Assembly, the US sends a large delegation, 30 or 40 people, usually with somebody from Health and Human Services leading it. often, sometimes a political appointment, sometimes a regular staff member who's been there for a long time. But frequently pharmaceutical company representatives participate as the US government part of the delegation. The progressive NGOs don't get a look in as far as that goes. So it varies in that way. On technical, particularly technical issues, the FDA and the Essential Medicines Program, or the Quality Assurance Program around medicines, have an extremely close working relationship. The epidemiological, the disease control, the emergency control group, they would have a link, but probably far closer with the scientific individuals in CDC rather than the political appointee.
I see, yeah. Well, it's just curious because when we quit, I guess is the word, last year, I heard the director of the CDC saying how much they had cooperated always with the World Health Organization, and that it had been a very important ally and collaborator and so forth. And so I was just curious if that was the main organization that interacted with the WHO for the United States.
For disease control issues, for pharmaceutical issues, the FDA is very much the leading group and organizer. For other areas, you see different people participating. But my observation has been it's tended to be CDC for diseases and FDA for the broader pharmaceutical area of interaction and the quality assurance and issues like that.
A final question. For example, when something happens, like at the Ebola outbreak or the COVID, how does this work? Can the World Health Organization say to a country, we need to come in and help you? Or do they have to wait on the country to invite them to come in to begin helping determine what's been going on? How does that actually work?
It's the international health regulations from 2005 were meant to address that issue, to try to make it easier for WHO to go in. And for small, poor countries, for example, in West Africa, you would have thought that with the Ebola outbreak, they would have done that. And yet there were long delays. WHO was slow, embarrassingly slow, in getting involved in Ebola in West Africa. Médecins Sans Frontières took the lead and documented and proposed activities. For the COVID situation, there the system worked more or less as it's meant to work. The Chinese central government authorities were slow to find out what was happening in Wuhan. The local authorities there suppressed the information and didn't communicate as they should. The mechanisms were there to do it, and as Hong Kong and Vietnam and Taiwan have shown, the experience they gained from the SARS outbreak had worked very well. But once the Chinese central government authorities did find out, they did communicate to WHO and said, this is a concern. The individual in China who synthesized, who identified what the genotype of the virus was, that was released relatively quickly, but it wasn't released through the WHO system. It was released through an informal network of people interested in COVID network. Now, once it gets to WHO, then it's up to they call this emergency meeting to say, is this a disease of international concern? And there's a stepwise approach. And people come together, and different countries had different motivations to say, well, it's not that serious. It's only people who've been in China who get it. And it was only when the asymptomatic transmission became clear that the idea is, yes, this is a global pandemic of great import. The issue of national authority and central and supranational. WHO is not a supranational organization. It's almost like what we saw here in the US, where the federal government had limited authority to go into states to say, we want to take specimens. If the state was not willing to cooperate, they were able in a very successful way to prevent that. At the global level, it's also very difficult in this way. I think at the end of the day, everybody recognizes that it would have been better if more countries had opened up earlier than they did. But we will see what will happen in the next epidemic. And, you know, go back to the H1N1 epidemic that occurred. That epidemic was labeled as the Mexican flu. Unfortunately, it was a US-based flu. The swine flu came out of the stockyards in the southern states that were staffed by Mexicans who returned to Mexico, caused infection there. But the stereotype that this was a Mexican flu didn't actually match the epidemiological and genotypical data that existed.
Well, Dr. Laing, I think we have finished all the questions, and we certainly thank you, because I think we know so much more now about the World Health Organization and how it works and the importance of it. And when we see now in the newspaper that the World Health Organization, this, that, or the other thing, I think we'll understand it just a whole lot better. And we certainly do thank you for your time, and it's been wonderful to have you with us and been very enlightening. So thank you very much, and good night.